So welcome, everybody. I see a lot of friends and a lot of new friends and familiar faces. My name is Andrew Tatarsky. I'm the director of the Center for Optimal Living. I'm a professor of professional practice here at the New School in our certificate program in harm reduction psychotherapy. I'm proud to say it's the one and only training program in harm reduction psychotherapy in the world, and we're in our second year. So on behalf of these two organizations, I'd like to welcome everybody for coming. And I really want to thank all of you for joining us to launch this really exciting and we think very timely and important program, the Psychedelic Education and Continuing Care Program. I'm going to read some words, which I generally don't like to do, but I have about 10 minutes and I really want to make sure I get the right words in, so forgive me. But I want to share a few words about the center to give you kind of the context, something of the context in which we decided to create this program. The Center for Optimal Living is a psychotherapy and professional training center that's a little over 4 years old here in New York City. Our work is based on a type of therapy that I've developed called integrative harm reduction psychotherapy. We might call it IHRP, which I'm going to describe in a minute. We have a team of 10 clinicians, and now for this new psychedelic program, we've brought together an amazing board of professional advisors, some of whom are here today. So I wonder if we can have the team, the clinical team who's here from the center, stand up just to say hello. Dr. Jennifer Talley is our assistant director. Dr. Michael Benibke is a senior psychologist, and both of them were part of the team that worked with me to open the center when we opened. Talking to you. We've also brought Dr. Katherine MacLean on board, and she's functioning now as the director of the psychedelic program. And Ingmar Gorman is a graduate student in clinical psychology who's been involved in doing MDMA research for MAPS, had a long interest in psychedelic research, and he's our administrative director. Stefanie Jones is a board member from the Drug Policy Alliance, doing harm reduction work with young people or in the kind of dance rave community. And Dr. Julie Holland is a very wonderful friend who wrote the book on MDMA and the pot book and a number of other books, and she's been an amazing friend of this work for many years, and she and I have collaborated with all of these folks. And we have just, FYI, when we're putting together our board of professional advisors, actually Charlie Wininger is here, he's one of them, a psychotherapist from Brooklyn. Gabor Mate is on the board, who said he wished that he could be here, so he's here in spirit. If you go to our website, you'll see just the amazing group of people. Everybody that we approached said they wanted to be on the board and wanted to be involved. So this is a really exciting team effort of researchers, clinicians, educators, people who have been doing this work and thinking about this work for a very long time. At the center, we offer comprehensive psychotherapy. We do highly individualized plans consisting of individual, group, family, and couple psychotherapy. The personalized, individualized piece is really the key to what we do. We have a special focus on helping people with risky and addictive behavior and trauma, as well as the full spectrum of mental health issues. And we have a particular interest in developing models for helping and services for groups of people who have really been underserved. And we think that drug users in general have been terribly underserved, and particularly users of psychedelic drugs. There have not been places, services, information, really available for this community, and this is really one of the major impetuses for us to create this program. Now, something about integrative harm reduction psychotherapy, which is really a radical alternative that I'll say a few words about. Over the course of my more than 30 years of working with people, primarily with drug issues, hi Jerry, another board member, I've been struck by the severe limitations and in some cases the damage caused by traditional abstinence-only treatment. I've been calling this treatment trauma, and I think that many people with substance use issues have really been badly damaged by the treatments that were supposed to help them. Out of my desire to develop a more appealing, compassionate, and effective approach to treatment, I developed integrative harm reduction psychotherapy. I wrote a book about it and a bunch of papers, which, some of which you can access on my website. It's an evolving approach to helping people with substance use and other risky behaviors. We think of it as extending the reach or emerging in relation to the limitations of traditional treatments. We recognize the complexity and multiple meanings of these behaviors and that they're best understood as reflecting the experiences of unique people in unique interpersonal, social, and political circumstances. So we think about substance use and other complex behaviors as being fully intertwined with complex factors. IHRP is based on principles of respect, acceptance, compassion, curiosity, affirmation, and collaboration. We think everything that most traditional treatment does not do. The harm reduction frame, which is the key, it enables us to meet people around their strengths, their needs, their motivation, and their goals, not our agenda. So we're really supporting people in finding their own truth and finding what goals and what path really are affirming to them. We support people in clarifying their ideal goals, whether increased safety, reduced use, or abstinence. That's really up to the person, and we want to support people in finding the goal that really best suits them. The integrative focus blends ideas and strategies from different therapeutic traditions to create personalized plans that promote clarification of meaning, mindfulness, and learning skills and active strategies for making positive change. So we're really thinking that unique people in unique circumstances need to be offered a blend of interventions and strategies that are really going to fit that unique context of the person. Substance use, and this is a little detour, but I think it's important for us to say, it's a health and human rights issue, and it should be treated as such. The criminalization and stigmatization of substance use creates exponentially more harm to substance users than the substances themselves, ever. We're filling our prisons with nonviolent drug users, we're destroying communities and families, and we're creating barriers for people. I think that this whole stigmatizing, criminalizing context actually works in many ways to prevent people who are concerned about what they're doing from accessing support and health. And we see these realities as negatively impacting drug users. At lunch today, we were talking about how, and maybe this is particularly true almost with psychedelic users and people interested in psychedelics, nobody ever talks about it. When can you talk in a constructive way about your psychedelic experiences that have been so meaningful or so frightening or so challenging? It's just something that's kind of off the, out of the conversation. So we challenge stigma in ourselves, in the people we work with, in society, and we're also explicitly anti-prohibitionistic. As our friend Ethan Nadelman from the Drug Policy Alliance says, in a free society, nobody should be punished simply for what they put in their body, absent of harm to others. That's the most serious violation of human rights we find in the drug war. So I think this is the context in which, the broader context in which we're having this conversation. So at our center, we've worked for years with people who have struggles with the whole spectrum of illicit and licit substances, including psychedelics. However, we think that there have been many developments over the last several years that have led us to believe that there's a growing need for specialized education and therapy services for people who are either considering using psychedelics or have used psychedelics. Also, the needs of this group of people, the therapeutic counseling support needs of this group, are generally different from the needs of people that struggle with other substances. And I'm not presuming that psychedelic users struggle with their use, but in many cases they do, or with the experiences that they've had. While the use of psychedelic drugs, such as psilocybin, mushrooms, LSD, and MDMA, remain illegal in the US, ongoing research from leading medical institutions such as UCLA, Johns Hopkins, and NYU have demonstrated the potential of these substances to promote well-being, enhance psychotherapy for trauma, reduce anxiety, and even help people quit smoking. And you know, the list of things that we're now exploring applications for is really growing and growing. Now, media coverage, I think in the last couple of years of these findings have led to an increased interest in the use of these substances for therapeutic, spiritual, and recreational purposes. In addition to a growing group of people who have experienced psychedelics in research settings, there's a significant increase in interest in and the use of psychedelics in a variety of settings, including underground and legal spiritual groups, that are using ayahuasca and peyote, the rave dance culture, healing centers in Mexico that are using a variety of different substances, ayahuasca, ibogaine, and others. Physicians are now administering ketamine for intractable depression, OCD, and other mental health issues. And we can also consider recreational users in general. But with the increased use, the possibility of increased harmful consequences increases as well, especially in unsupervised settings. And there are currently few opportunities for people who are seeking some kind of professional help, around their experiences. So our program is designed to assist people who have had psychedelic experiences and are seeking support in connection with them. As people who are interested in the use of psychedelics but may not have had personal experiences, or as well as them. Our overarching intention for the program is to increase awareness and reduce risk. We see this as a natural extension of the harm reduction approach that we've been using at the Center for Optimal Living for years now. Let's consider some of the things, and this is what our panel will be talking more about, the kinds of issues, experiences that people might consider seeking some kind of support for. Individuals who have had difficult experiences can benefit from a better understanding of the often challenging feelings that are stirred up by psychedelics. For some users, the effects of psychedelics can make an even ordinary, familiar experience overwhelming, particularly when experienced alone or in less controlled settings like music festivals. Others might remain confused or anxious long after their experience is over and have difficulty processing the conflicting thoughts and feelings that came up. I worked with a woman who was actually part of the so-called psychedelic community, who had a DMT experience, and she felt like for months afterwards she was just completely out of alignment on every level, emotionally, spiritually, physically. And we worked together to kind of get her back into balance. In some cases, I think these experiences can be traumatic. And in some cases, panic can lead to desperate actions, which unfortunately can put people in tremendous danger. Individuals who have had positive experiences, I think, can also potentially use supportive therapy to bolster and integrate insights from their experiences. Positive experiences can pose significant challenges. When they arise, for example, in a discrepancy between insights people have gained and the basic assumptions that one has about themselves, their lives, their relationships, reality. So I think across many different kinds of experiences, there can be some real value to having a place that can help process and integrate. Previously, individuals seeking support for psychedelic experiences or simply looking to better understand and make use of the insights they gained have had few, if any, options for some kind of professional support. The Psychedelic Education and Continuing Care Program is tailored to meet people with full engagement, full respect, full support, and open curiosity, and support people in navigating either a curiosity about using or experiences that they need help to work with following the experience. So that's an overall introduction to what we're doing. After we hear the presentations, I'll share a little bit about the services and the things we're thinking about doing immediately, and then some ideas that we have long term. I think we would also then like to open up the conversation to this group to hear your thoughts and feelings about what can be valuable, what's needed, what you would like to see. And we see, in the sort of part of our fundamental commitment to collaboration is to work with communities and people to actually come up with novel ideas about what will be helpful. So thanks very much again for being here. I might also mention we do a lot of public forums on different topics that we think are quite important. And this forum brought more people than any of our other previous forums. So I think that speaks in some way to the relevance and the importance of what we're doing together. So thanks so much, and I look forward to continuing the dialogue later on. So let me introduce Dr. Katherine MacLean. She was on the Johns Hopkins team studying psilocybin and its impact on quality of life, and a number of things she'll be talking with you about. And let me just share a little bit of the lovely history. I've been thinking about doing something like this for a long time. And a year ago, I was at the Horizons conference, and I heard and met Katherine for the first time, heard her speak. And I was so impressed by her and her work and her energy. And I heard her say that she had just finished a sabbatical from Johns Hopkins, and she didn't have a job. And she was wondering what she might do next. And I approached her afterwards, and I said, well, I have a center. And our center is really interested in being a platform for people doing amazing work like you've been doing and you want to do. So we began a conversation a little over a year ago. Then we brought Ingmar on board and Jen, and this program today is the result of our fortuitous meeting and collaboration over the last year. So, Katherine.
Oh, this doesn't want to change height. Let's see if I can. Nope. All right. Well, that's where it's going to be. Okay. How's that in terms of volume? Okay. It's really exciting to be here tonight. I tried out this joke earlier, and my husband said I should say it to kind of break the ice. Another friend of mine thought he would only come if I said something controversial, so this will be the only controversial thing I say. I'm a new mom. I have a 4-month-old infant, and so all of you know how important tonight is. It's taken a lot of preparation to get to the point that she could accompany me into the city to do this, and it's also the first time in 4 months that I've worn a bra. So. Life on the farm is very easy. So it feels like a long time ago that I was at Johns Hopkins, and I'll share a little bit about some of my personal trajectory through that experience to help illustrate how I came to kind of be here rather than still there doing the really good research that is ongoing. I joined Johns Hopkins team in 2009, straight out of graduate school. Working with psychedelics was something I had wanted to do since I was about 19 years old. And at the time, although I didn't know it, and really no one knew it, the Hopkins research had just begun in about 2000. When I was in the middle of graduate school studying intensive meditation training and mindfulness, Roland Griffith's paper first came out, the study that showed that a high dose of psilocybin could produce mystical experiences that were indistinguishable from what religious mystics and saints across history have claimed. And I said, I know where I'm going next. And through many fortuitous, kind of synchronous events, I wound up sitting across from Roland in his office, and that was kind of the beginning of a major journey. The time at Hopkins was intense in many ways. When you see the media reports of the research, what it doesn't really capture is how hard everyone is working behind the scenes to produce the results. And by produce, I don't mean kind of manufacture the results, but to allow the sessions to occur and to write up the results in a way that does justice to the people who've been involved, the volunteers themselves, and their life change that has happened under the course of the study, as well as being true to the science and being as objective as possible with something that is very, very powerful. And I think none of us would really be here if these substances weren't already fascinating, powerful, compelling, and also a little bit terrifying. And so these researchers are giving some of them in their whole lives to being able to share this with the world. So the work was intense, and I was a researcher and also a session guide. And I'm very honored to work with Andrew and Ingmar and Jen and Mike, because I have absolutely no clinical training. All I'm trained to do is sit in a room with someone on an unknown amount of psilocybin and help them along the way. And I'll share a little bit about what I saw in that session room and why I think that this kind of harm reduction approach is needed at this time as the interest is growing in terms of the therapy. So on the one hand, we saw a lot of really great outcomes. 70% of people across all of the studies, almost 250 people have gone through and taken psilocybin as a part of the Hopkins project since 2000. So across 250 people, 70% of them self-reported that they had a mystical experience that, again, reached a level that was considered complete, or it basically maxed out all of these different categories that religious scholars had said, these are the categories that saints and mystics have described across history. So 70%. That's a really great response rate for someone who shows up in the course of a month, gets to know us, takes a capsule and lays on a couch with eye shades and headphones for 7 hours in a room with no windows and interacting with none of the people that they know in their life. And then they kind of go home that day to their friend or family member. And at the end of that session, and the next day, and the next week, and 2 months later, and a year later, they are still saying it was one of the most profound, and for some people, spiritual experiences of their entire life. So these are the results that Johns Hopkins has been churning out. And it's almost too good to be true until you see it happen every single day that you show up to work. So I can tell you, having been on the inside, the results are true. There is a lot more to understanding psilocybin than those results. And what we also found is that on a high dose, 40% of people reported strong or extreme panic, anxiety, fear, distress. So 70% mystical, 40% the classic bad trip. I witnessed a few of those in my time at Hopkins. The safest thing I could say about what I saw without revealing too much for the people who were involved is that one person encountered all of his worst fears. He felt like he was going to die, and the only lifeline that existed was my hand holding his, and the fact that he trusted me and the other person, the other session monitor in the room, to lead him through the experience. Another person became so dissociated, which is unusual in psilocybin, but it can happen, became so disconnected from his body and the room that he no longer remembered what was happening. And I think that those of us who've seen recreational use of psychedelics, this is actually more common than it is uncommon, especially at festivals like Burning Man. I did harm reduction work with the MAPS Zendo project at Burning Man and at Africa Burn. And the response rate for mystical experience was not 70%. And the response rate for bad trips was not 40%. It was much higher. And so the truth is somewhere between what I saw in the session room at Hopkins and what I saw with the Zendo project, working with MAPS. So a little bit back to kind of my personal trajectory. Why on earth did I leave such an amazing place to work? It seems like a dream job, and it was in many ways. But in early 2013, my younger sister, she was only 29, she went into the hospital unable to walk up a flight of stairs without catching her breath. And she found that the cancer that she thought had been cured, breast cancer, had actually metastasized throughout her lungs. And she died very rapidly in about a month and a half from that moment of not being able to walk up the stairs until basically being in the hospital room with the doctor saying, I think this next round of chemo will work. And the best drug she had available to her was morphine. And the morphine was a godsend. And she was able to experience palliative sedation in those last hours of her life. But I thought to myself in that moment, there has to be a better option for dying, especially for a young person like this who has not had the opportunity to live her whole life, who has not had the opportunity to see her 4-year-old daughter grow up. And I don't know if that better option is psychedelics or if it's something else. But something that I saw in the Hopkins sessions was that people, 30% of them, not as much as mystical, not as much as bad trips, but 30% of people experienced a profound understanding of their own death on a high dose of psilocybin. So imagine what that means for a young person who's feeling her life being ripped away from her without her control and being able to experience that before she dies. Think about that for her family members who might be able to understand a bit about what she's going through. These are kind of my visions for what we might see eventually if any of these medicines are eventually rescheduled. Of course, the data have to come through. We still don't know if the data will kind of support a rescheduling of psilocybin or MDMA, but the results are promising. What I do see is that that vision may be very, very far in the future. And so I thought to myself, how do I honor what I saw in my sister's hospital room and help people who are feeling that they are in the stage where they are going to take matters into their own hands, whether that's someone who's dying or someone who's been majorly depressed their whole life and nothing has worked, someone who has, like the patients in the NYU study, has severe anxiety about a cancer diagnosis and they can't live their lives, even though they know the cancer, they've been told the cancer isn't going to come back, but they still can't really get over this anxiety of the pain, the treatments, the trauma, potential death. What about the young people who are just striving, seeking for that sense of connection that is bigger than themselves? How can we help them have a better outcome so that a single experience just doesn't become, oh, it's something really fun I did when I was 20, but that was a long time ago and I forgot about it? How do we help people integrate those insights into their life? For the young people like the person I saw in the session room who became so disconnected that the experience itself could have been traumatic if not for the help we provided them afterward. How can we help them have better outcomes so that on the one hand, they don't experience this trauma kind of perpetuating through their lives, or maybe go back to the drug to try to have a better experience? That could happen either whether the experience is positive or negative. You want to keep going back to have that connection again. What I found is that when I talk to groups who are very pro-psychedelics, I end up encouraging them in the other direction, saying kind of look at all these other options that are available. These are Schedule I drugs. It's a real risk to yourself and your families and your freedom to be taking these drugs. And it's a real risk to your psychology, to your safety. When I speak to groups who are kind of anti-psychedelics, I kind of encouraging them in the other direction and trying to, again, point out, like I pointed out tonight, all of the potential positive outcomes. So maybe what this program can do is to help people kind of meet in the middle. If there are people, and I'm sure we know them, who are overusing psychedelics and maybe causing harm to themselves and others, could a program like this allow someone to, in a really safe, supportive setting, speak with a therapist or in a group about their experiences and learn how those experiences are a part of them and are not just limited to the drug? So maybe that person ends up reducing their use or even stopping their use. What if someone has read the New Yorker article and this person is 60 years old and has a kind of mild form of breast cancer and is like, I'm going to go do that? Should that person do that without any experience and not being in a community of support? I don't know. Now, maybe that person has an avenue, has an option to show up to one of the groups, sit back, listen, learn a few things, and maybe make a better informed decision for herself. Something else I want to share. The researchers at Hopkins, NYU, UCLA, in London, we are inundated all the time with emails from desperate people saying, please help me. How can I get in the study? What can I do? And basically, if I don't hear from you, I'm going to have to do something on my own. And there's nothing really we can do. We're not in a position to help those people. That has happened so much that I hope that some of those people will find their way to this program. And again, we're not condoning or encouraging or recommending that people do something that is inherently dangerous given the laws in our society. But we are saying, here's a way for you to learn more. If you're thinking about it, if you're curious, if someone you know is using psychedelics and you want to learn more about whether it's damaging to them. And here's a place you can come if you've had an experience and you don't have anyone else to talk to. And hopefully, no matter how long that vision for the future takes, I think it will happen. In whatever form it happens, I think it will happen. There will be a shift. However long that takes, at least we're helping people in the interim. And that feels to me authentic, and it feels to me to be consistent with the work I did at Hopkins and also kind of where I find myself now. And I think that's all I would like to share tonight. The other funny thing about being a new mom is like 90% of your brain is completely taken over by this mini human. And so parts of my brain that I used to use to remember facts and do research and write papers and give talks is gone. So I hope that 10%, whatever's left over, was helpful to you tonight. So I'd like to introduce Ingmar Gorman. Ingmar has been such a privilege to work with. He seems to have unending time, energy, skills. I can't even keep track of all the things he's doing. But the amount that he has done to make tonight happen, and on behalf of the program, we all owe a big thanks. And he's going to speak to you about MDMA and how MDMA has been used for assisting psychotherapy. So the MAPS organization has been doing the MDMA clinical trials. And specifically, his views on how integration after the experience was critical to helping people have the most positive outcome and the least harm. So, Ingmar.
Thank you. Can you hear me okay from here? This good? Yeah? Okay. So, yeah, thank you for the beautiful introduction. And hearing that you should talk to my partner, Erin, about my, endless amounts of time. She knows that when I come home late, I'm totally exhausted. She's there to support me, so appreciate it. Well, the first thing that I really want to share with you is a little bit of my feeling of nervousness. And I think it's a good nervousness, but I feel really like we're doing something with this program that's new, that hasn't quite been done yet. There is actually a group on the West Coast named Erie who has been doing something like this. But it really feels like we're meeting a kind of unmet need, or maybe an unrecognized need in the community. And that's really exciting, but it's also new territory. So maybe to begin, I'm going to tell you, like Katherine, a little bit about myself and how I came to this point so that you can understand it. And then tell you a little bit about my work with MAPS and how I hope that would inform, or how it will inform, what we're doing here at our program. So my first entry into this world was as an undergraduate at a liberal arts college called the New College of Florida. And I was determined to do something related to psychedelic research. And I was fortunate enough to have a connection to the Czech Republic. And I went to my thesis advisor and I said, I want to go to the Czech Republic, and I want to find the people who were treated with psychedelics during its period of legality under communism, and I want to see what has happened 40 years later for them. Where are they? And my academic advisor said, well, that's a potentially vulnerable population that you're dealing with. You're not a clinician. Something could come up for them and you wouldn't be prepared to deal with it. So how about you interview the psychiatrists and the mental health professionals that were doing that work, because they aren't considered to be a vulnerable population. So that's what I did. And our central question really was, we knew that part of the training back then was for people who were administering these drugs to also have their own experience. It was part of their education. And we wanted to know, what did they get out of their experience, and how were they trained and how were they educated? This is from a period of roughly, the early 1950s to 1974-ish. So that was my first sort of diving into that world. And then I came here to the New School. And I thought, well, I want to become a clinician. And if I'm going to be studying these things, psychedelics, I should know about the full spectrum of substances and different ways people use substances for better or for worse. And I happened to, I find this to be very serendipitous. I took a class with Jen, and 2 classes with Jen. And I was introduced to this idea of harm reduction psychotherapy, this framework. And it was very fortuitous because I think that I could have landed in so many different places in this country and have been exposed to a kind of approach to drug treatment that would have ignored or completely censored my interest in psychedelic medicine. I don't think it would be something that would be able to be discussed. And the fact that the harm reduction approach allows for this dialogue is why I'm so happy that we're doing this here. So to tell you a little bit more, I was here at the New School and I started to become more open about my interest in psychedelic research, and I found the faculty to be quite welcoming. And I had this connection with MAPS that I'd been developing over the years. And I approached them and said, I want to be involved somehow. And during this time, I was fascinated with this idea of psychotherapy process, or psychotherapy research. And this is something that I'm now kind of obsessed with a little bit. The idea simply being, with all of these treatments, whether it's with psilocybin or with MDMA, the idea is that there is a synergy, right, between the substance and the psychotherapy. And right now, where we are in the research, in phase 2 clinical trials, you don't have an N and a sample size, or really it's not the mission at this point to identify how the psychotherapy works. The mission is to show or to investigate whether it works or not. Possibly in the future, we could then begin to examine what are the psychotherapy variables. But my interest in that sort of had allowed me to see a little bit into how the psychotherapy is conducted and begin to generate hypotheses about what might be important, in particularly the MDMA treatment for post-traumatic stress disorder. So I, with a group of students here over the years, have observed psychotherapy sessions over video with the MDMA. And I started to look at things like the therapeutic alliance, so the relationship between the patients or the participants and the therapists. I started to look at general sort of psychotherapy variables, and also what I'm really fascinated with right now, which is sort of how a person tells a story. When they're going through the treatment and they begin to maybe speak about their trauma, how are they talking about it? What's the quality of their speech? And then how do they then reflect on that particular story, and whether that's connected with their change, with their improvement over time. And simultaneously, I'm talking about all the things that I do, I've also been involved with this group called, or what it is, an adherence research team. And so when you develop a psychotherapy, what one group of people often will do is see whether the therapists are sort of following the manual, so to speak. And I have to give credit to MAPS, because the manual which is, by the way, accessible to anybody. It's online. You can just Google, I think it's the MDMA PTSD therapy manual. What you'll find is that they are actually quite open in terms of how therapists approach these sessions. So it's not too rigid. It's flexible, but also has very important safety guidelines. And so my role in that was to sort of supervise that project and something that's ongoing. So what about this program that we're starting, right? So I'm hoping that some of my experience and what I'm studying and what we've learned or learning can inform the psychedelic program we're starting at the Center for Optimal Living, particularly, as Katherine had alluded to, the integration moments, right? Which is that a person has an experience with MDMA, and it may be the next day, several days later, weeks later, months later even. Things might continue to come up for that person, right? And in many contexts, there's intentional use, and then there are other sorts of ways of using, and not to create a hierarchy, I don't want to do that, but there's a way that one is more encouraging of reflecting on their experience and one that's less so. And what we really want to do at the center is to sort of change the way that people are thinking about these experiences, help them be a little bit more reflective and understand how these experiences come up in their life, in their daily life, in their relationships, things like that. So I do want to make one, we're talking about MDMA and psilocybin as if sort of they're both psychedelics, and many of you will know that MDMA is sort of technically not a psychedelic, right? And there's important distinctions between the two. So whereas psilocybin may have this potential to create a sort of bad trip, it's generally less likely with MDMA. Certainly somebody's traumas and also many things can come up that can be difficult. But it has a different profile than psilocybin. On the other hand, generally you won't see adulterated magic mushrooms, right? No one's going to put something in them. Maybe somebody has tried, I don't know, but that's generally not what happens. But with MDMA, this is an issue, right? Because you get a powder or you get a pressed pill, and a person really does not know what is in it. And so, and this is particularly true now in the last 10 years, 5 years, where we've really seen a surge in the availability of various what are called research chemicals, or a better word would be, maybe a better phrase would be sort of novel psychedelic compounds, psychoactive compounds. So this adds a whole new dimension to working with somebody, both in a Zendo kind of context, right? But also in the aftercare, sort of understanding what a person has even taken, right? And how do you work with the person afterwards? So I'm thinking about maybe keeping my, Andrew and Katherine did such a great job of sort of summarizing what we're trying to do. I might keep this a little bit short, but maybe one thing to add before I pass this on to Stefanie is that I do think that there is an unmet need here, and particularly amongst therapists. I myself am almost a clinical psychologist towards the last year of my Ph.D. here at the New School. And I think there's definitely shame and there's definitely stigma to begin to sort of look at both sides of the sort of psychedelic coin, right? Particularly, I think the way that things are leaning in most of the country, if I were to make an assumption, is that if somebody has used a psychedelic, then it is an indicator of potential substance abuse, right? Or that if somebody were to evaluate somebody and that would come up, some people might even think, oh, well, should this person be referred to a substance abuse program, right? And now, how does that feel for somebody for the user, for the person who's sitting there? I don't usually like to refer to this, but it's scientific, we have science to now support this idea that, some psychedelic experiences for some people have been one of their, top 3 most important experiences in their life, right? It's something that's said often. Now, how do we deal with that, right? We have a group of people who are identifying this, a significant group of people, large number of people who have had this experience, who identify it as very important to their own personal growth. And then on the other hand, we have mental health professionals, not all of them, but many who feel like this is something that should be sort of be careful. Like we should be careful about how we talk about this. And so one thing that I'm really hoping that this program will do is not just geared towards people who are curious or have a history of psychedelic use, but for an education program for clinicians who might not know anything about this world. I mean, they're most likely, I hope they're here in this room, some of them, but my feeling is that most people here are sort of have an interest in this. But there's a whole group of people out there who are working with people who've had psychedelic experiences who really don't know what's going on. And I really hope that one thing that we can do is educate these people as well. So thank you for coming. And I will say a few words about Stefanie. So Stefanie is also on our board of advisors. And as I've told her before, I really appreciate her voice. I think she represents a community of people who are truly, have been neglected in this area. And well, I'll leave it to her to say a few more, but she's with the DPA and she's great.
I have some pretty pictures for you to look at, so give me 1 second. It worked. Okay. Hi. My name's Stefanie Jones, and I'm with the Drug Policy Alliance. I run a program called Music Fan, which I'm going to tell you about. So first of all, the Drug Policy Alliance, in case you aren't already familiar, we're a nonprofit advocacy organization working to change drug laws so that they are more reflective of health principles rather than criminal justice principles. The headquarters is here in New York. I've worked for DPA for 10 years, and I've only just started this program, mostly for reasons that Ingmar was kind of mentioning. I myself am a member of the festival community, like the electronic music community. I don't like to use the word EDM. But, you know, I worked at this drug policy organization for many years, and we spent a lot of time talking about marijuana and legalizing marijuana, and we spent a lot of time talking about opiate overdose prevention and syringe access, and all of those things are really, really great and important, and I'm so proud of the work that my organization has done. But it became a little frustrating for me to, like, you know, have to explain over and over again to my friends I was going out to parties with where I worked. I'm like, you should care about this. It's relevant to you. We're all using drugs, and, you know, this is a risky endeavor, both for health reasons and because we might get arrested. So it was that impetus that led me to start the Music Fan program, which is really to promote health and harm reduction approaches in nightlife and festival settings, in any music scene, really. And so a lot of what I do is just promoting the services of other organizations, which I'll tell you about in a sec. Before I get there, I want to spend a little minute talking about what we mean by this whole recreational psychedelic use phrase. So I think a lot of times in the community when we're talking about psychedelics, there's obviously an emphasis on the research, which is important, and there's an obvious emphasis on the usefulness of these substances for medical treatments and for therapeutic uses, all of which is great. The organization MAPS, which has already been mentioned tonight, doing really great work in that area, and we're happy to support them. When we talk about recreational psychedelic use, people have a tendency to sort of, as Ingmar was saying, make a little a hierarchy and kind of frown upon that or look down on that as if it's not as important or as relevant in people's lives. And I would have to say that I think within recreational contexts is one of the major ways that people actually experience psychedelics. This is the largest population of people probably actively using psychedelics. Maybe oversampled in this room, people who have done it more intentionally and more spiritual settings, but in the general population, I think that the way most people come across psychedelics is at a festival, at a club, at a concert. And the results of that are kind of messy sometimes, kind of messy. And Andrew was referencing that before, and that's definitely an issue. So when we talk about recreational use, people think, oh, this is just a community, they're just going out for fun and that sort of thing. They're not thinking very much about what they're doing. That may or may not be true. I think in my experience going out, I've certainly met people who are very intentional about their use. They have, goals about learning about themselves, personal growth. I've also met people that were clearly medicating in some way. They were trying to heal something about themselves. So I think we have to be a little bit thoughtful when we talk about what recreational psychedelic use means. It can mean recreational for the purpose of fun, but it can also just mean it happens to be taking place in these type of settings, that are sort of purpose-built towards that. But it's hard to know people's motivations. Nonetheless, as I said, kind of messy, can get a little bit crazy with people taking substances that they're often not very well informed about. And so there are two really important strategies that the Music Fan program is trying to promote and expand in different club and festival settings. And I'm going to talk about the two of those a little bit, which you're probably familiar with both of them, but I think it's the foundation for what I'm hoping this program is going to do outside of a party setting. So in a party setting, the first thing that you want to do is give people a chance to learn about what it is that they might be taking that night. Young people especially are often not very well informed about these drugs. They might have just been handed it, by a friend. They might have, read something online, and we all know that everything that's written online is totally accurate all the time. So, setups like what DanceSafe will put together are really important. These are, info booths where it's peers talking to peers, answering their questions about, what is this drug? What is it going to do to me? Like, how is it going to make me feel? Like, what if I mix it with this? Like, all the really, really honest stuff that in a therapy setting or something like that, like those kind of questions, again, they're often stigmatized. They're often triggers for, you to be moved towards a substance abuse kind of thing. But in a party setting, the emphasis is on this harm reduction approach, which is really usefully applied by DanceSafe. The other thing that happens, so you try and educate people, you try and get them before they've, taken something, made a decision that they don't know about. It doesn't always happen. So sometimes people get out there, they get excited, they're doing it, and they don't know what they're going to get into. So the other service that we're trying to expand and promote is something that I have rebranded as on-site mental health, but is classically originally known as psychedelic harm reduction. And it's been mentioned a couple times already. The Zendo project, which is a project of MAPS again, is essentially setting up a safe space for people to come if they're having some kind of difficult time. And, Katherine was mentioning, it's oversampled. People are not generally having these amazing experiences when they come to Zendo. They're having the difficult ones. That's a little self-selecting, right? Like if you're having an amazing experience at a festival, you're having an amazing experience. You're there. You don't need to talk to anyone except for your friends around you. But these services are really important for the people who are maybe unprepared, or even if they were prepared, just kind of, for whatever reason, something took a turn and they need a little time to sit with somebody, to be a listening ear, to be a help in some way. And so promoting these two things and getting them in more and more party settings is one of the biggest goals of the Music Fan program. And I work very closely with folks at Zendo and DanceSafe to try and get this happening in more and more places. It's unfortunately not happening in enough places yet, which is part of the reason I'm excited about the potential for this program. Because the other thing is, sometimes talking to people at a party setting is not really the best idea. Maybe they're not receptive there. Maybe they're not, really listening. There's a lot of distractions. you know? So it's important to give people as many opportunities to learn and ask questions, I think, as possible, especially with these substances sort of like, you know, getting a little bit of an uptick in media attention, getting a little bit of an uptick in sort of conversation culturally. You know, the medical research is really pushing broader acceptance, or at least sort of conversation around this. And so I think that this program has the potential to create spaces for people who are questioning and have questions before they get to a party or festival setting, or before they engage in some kind of intentional use, whether it's in a party setting or not. And I will say also what's so exciting about having education and continuing care outside of the party setting is there's only so much you can do on site. Like, you can educate and you can sort of sit with somebody at the moment that they're having like a crisis, but you know, as others have mentioned, you know, you go home from that party, you go home from that festival, and it might still be with you. And like, up until now, there's not a whole lot you can do with that. Like, education was like asking your friend something. Integration was like saying, hey, can you help me out with this? Like, it would be better, it's much better to like, you know, have people, trained therapists and others who understand the harm reduction approach, won't be like stigmatizing, and will be made, you know, be available for people who want to engage in those services. And to reference back, you know, the people who aren't having difficult experiences, who are having amazing positive experiences, those too can be very challenging to like change your life and whatever, you know. And again, people in recreational settings, like, they've had this revelation, you know, this is a classic Burning Man thing, they've had a transformative experience and they want to change their lives, and that's completely authentic, but you know, nobody is really organized to help you with that. And so that, I think, is really it really highlights the potential of this program. So I'm gonna end there, because I think I'd like to hear from all of you, and we have one more amazing speaker who I guess I will give an intro to.
Good luck.
I'm completely unprepared, so all of this, you know, is coming from my heart. But Julie Holland is an amazing woman. Her book on MDMA was like formational for me. It was like so inspiring just to have all of that brought together, and so early on, really before a lot of people were writing about that. And so she's continued to do amazing work, both writing and in her private practice, and I'm happy to have her follow me as a speaker.
So Stefanie mentioned messiness and crazy, and like, that's where I come in. That's what I like. So I'm a psychiatrist. I have a private practice in Manhattan. I used to work at the psychiatric emergency room at Bellevue Hospital. For 9 years, every Saturday night and Sunday night, I ran the psych ER at Bellevue. It was an amazing job. I loved it, but it was very messy, and it was crazy. And it wasn't that often that people would come in tripping or high on psychedelics where they needed care, but every once in a while it did happen. And I always, you know, felt a certain kinship with those patients. It kind of reminded me of, you know, being back in high school again with my friends, where there was sort of wonder and awe at everything around them, feeling like everything made sense, everything was connected. I mean, it's not always a euphoric experience, but sometimes in an altered state, there is this epiphany of everything being connected, and there's a real joy around that. Feeling like you're hooked into some sort of lattice work of energy, feeling connected. We're social primates. We like to feel connected. Being isolated is very bad for our mental health and physical health. So, and the whole issue of connectedness, you know, one of the interesting things about the brain on psilocybin in particular, there's just more work done on psilocybin. I imagine you see the same thing with LSD, but there is this sort of hyperconnectivity between neural networks. When somebody is tripping, there's an awful lot more connectivity going on than usual. And there's also this sort of frontal release, where you don't have the frontal lobe saying, okay, stop that, you have to pay attention to this. You're sort of allowed to make all those connections. There's a Robin Carhart Harris is a more recent person who's been looking at this. And the first person who was really looking at connections with psilocybin and loosening of associations is this guy Manfred Spitzer, somebody very early on that I thought, this is an amazing paper. Hard to track that paper down now. You'll see a loosening of associations. This idea of loosening of associations, it's sort of a classic label for somebody who's in a manic episode, who's making connections. You know, they may be talking, and they're sort of going from topic to topic to topic, and you don't quite know how they're getting from one thing to another. But if you look, you'll see that they're actually connected. And maybe they're connected by sound, and they're rhyming, or they're connected by sort of a far-reaching thought. But if you're a little bit poetic and a little bit loose and receptive, you can see where a manic person is making these connections and how they're getting from point A to point B. You also see this in psilocybin. You see a loosening of associations. And I think it has to do with this hyperconnectedness, where the brain is starting to make more connections, and it kind of makes sense to the tripping brain. You also see new connections, neurogenesis, neuroplasticity, growth of new nerve cells. From psilocybin, and that's some work that came out, I think, back in 2013, but for some reason it's getting a lot of Facebook attention recently. Somebody dug up an old article, I think. Anyway, so it's this idea that sort of everything is magical and there's a sense of awe and that everything is connected, and I think that this is, for a lot of people, is a very euphoric experience, and you'll see this in mania too, that there can be euphoria in mania. But you can also see paranoia and agitation and real fear in a manic episode, and obviously in a psychedelic episode. Now, some drugs seem to create more fear and unease than others. I think that psilocybin, in my experience, and whenever a patient comes to me and they're new, I always ask them about their drug experiences. And I will often hear about bad trips with LSD or something else. But it seems to me that psilocybin does tend to lend itself to fewer bad experiences for people who are prepared. And I think that there is a real reason, specifically with LSD, that the liver creates this metabolite, an active metabolite in many people, not all people, called 13-hydroxy-LSD, right around the 5th hour, where you may sort of get into trouble and start to have a negative experience. Anyway, suffice to say that there are certainly people who have trouble integrating their psychedelic experiences when they sort of come back down. And other people have trouble sort of pharmacologically, where the psychedelics end up being destabilizing. And even heavy cannabis use in some people can be destabilizing. So what do you do with someone? I mean, I get this every once in a while. Well, I'll have somebody referred to me, a new patient, or somebody calling me about their kid. They went off to college. They took a lot of acid, they took ecstasy, they went partying, they were not sleeping well, they're not eating well, and now they're psychotic. And the question is this a first break? Are they psychotic? And that they have a psychotic illness? And is this mania? Is this schizophrenia? Or is this just a kid who's been tripping a lot and is having a lot of ideas and is having trouble sort of processing it? And that can be really tough to differentiate and distinguish. I am a harm reduction psychiatrist. I don't necessarily preach abstinence or insist on abstinence, but if I do have somebody who is in this sort of manic and disorganized and terrified state, I will typically really encourage abstinence just so we can figure out what the hell's going on, and whether this is their own chemistry, or whether they've triggered something with the drugs, or whether it's just there's so much to process. So. Sometimes people bite off more than they can chew. And the thing that some people really need after taking these big bites and getting a lot of information is they need to process it, and they need to make sense of it, and they need to download it. And so the chewing sort of comes from the therapy. So, but it's true that a lot of people, if they go to a psychiatrist and they start talking about, what they need to process, they're going to be put on antipsychotics, or they're going to be shifted off, to a detox or rehab facility. I need some water. Okay. So you can always send them to me. I can always work with Andrew. I'm happy, very happy to refer to Center for Optimal Living. It's a great resource to have in the city. It's a much needed resource. A lot of people need help, and there is a lot of stigma And it is messy, and a lot of people need more training so that more people can help. So I feel like what we're doing here is very important. So I also wanted to talk a little bit about this weird thing that not a lot of people know about, and I don't know a lot about it, but we need to know more, and that is what happens when you're mixing drugs. You know, I had a patient email me. He's in Hawaii. He was trying to find somebody who could maybe get him some cannabis, but he ended up stumbling upon somebody who could get him ayahuasca, and he's emailing me like, is it okay to take ayahuasca with my Lexapro? No, it's not, it's not okay. There are some drug combinations that are medically dangerous. There are some drug combinations where you're just going to get much more high than you were intending, and there are other drug combinations where you're basically, even if you bought something pure, if you're fortunate enough to get something that isn't adulterated. MDMA is the most adulterated drug on the planet right now. I can say that, with safety. It's harder than ever to know what you're getting, and with research chemicals, it's double harder than ever to know what you're getting. So I don't necessarily want to get into too many specifics, but I will give you some examples. That if you're on lithium and you take psychedelics, you are going to get much more high than you planned on. If you are on antidepressants and you try to take MDMA, you're not really going to feel the MDMA. It's not going to work. The antidepressants are sort of blocking where the MDMA needs to go. Ayahuasca does not play nicely with a lot of other medicines and foods. And you need to be educated prior to taking ayahuasca so that you don't get into a situation where you have a very high blood pressure and a hypertensive crisis. No one is doing research on this. No one is going to pay for this research to happen. The best we're going to hope for is sort of passing the word along and anecdotal reports. And so, I really like Arrowwood.org. I trust the content at Arrowwood. In terms of anecdotal pooling of data, I trust Blue Light. But it's not easy to get information on this. And I definitely have patients who are on medicines but would like to be able to go to Burning Man once a year, for instance. And so, sometimes we need to taper down very slowly the medicines in, June and July because they're going to go away in August. Obviously, your average psychiatrist is not comfortable doing this. And, I respect that, but somebody needs to do this because it's happening. And people need guidance and assistance so that they don't hurt themselves. I had a patient who ordered some powder from China that was like a benzo. So some sort of sedative, another one of these sort of research chemicals, but he ended up sedated for 3 days, like heavily sedated for 3 days. His mother was freaking out, everybody's freaking out. We found like on the computer what he ordered, and then it's like I'm trying to learn about this chemical I've never heard of, and there's not a lot of information out there. And that's sort of what I'm faced with every once in a while is just, big missing data, what we call 99 when you're plugging in data. Like you just, I don't know, 99. No idea what this is, how it works, what I can do for this guy. So, in terms of good data collecting, one thing that I often talk about is how important it is for there to be transparency between organizations. MAPS is doing a lot of good work. Hefter is doing a lot of good work. It's good if we try to pool protocols, if we have a lot of transparency about exactly the milligram strength we're using and what outcome measurements we are gathering, because if you can pool the data, you will have more power. And knowledge is power. And the whole point of harm reduction, like sort of, the first commandment of harm reduction, I would say, is to just get as much information as you can and to share that in a non-judgmental way. So research is important, and people outing themselves is important. Something we talk about a lot in the psychedelic community, that if everybody could sort of out themselves on their psychedelic history, maybe on Bicycle Day, or perhaps people could out themselves about their own cannabis use, perhaps on 420, what I like to call the high holidays. There's Bicycle Day, there's 420, and there's Earth Day. So like those are my high holidays. I think that, people outing themselves about their own use and sort of standing up and being counted is one of the surefire ways to sort of move drug policy forward in the right direction. I love Q&A. I live for Q&A, so I'm going to stop so that we can answer questions. But Andrew looks like he may have a word or two.
So I was asked to say a few things about our services. But before I do that, I want to say a few things about harm reduction and giving people permission to use drugs. We don't give people permission to make the choices that they make as individuals who, own their bodies and own their lives. We don't promote psychedelic use. This program is not promoting illicit, unregulated, underground, risky use of unknown substances of unknown purity. Psychedelics are illegal. They're unregulated. As Julie was just saying, MDMA or ecstasy or Molly may be a combination of ketamine, caffeine, MDMA, cocaine, methamphetamine, and whatever else they had in the medicine cabinet. And I just read something that in England right now, the dealers or the manufacturers are having some kind of a war such that they're starting to put out tabs that are 200 and 300 milligrams, which can actually put somebody in a very, very bad emotional and physical state. So we don't give people permission to use psychedelics. We don't promote underground psychedelic use. Just like we don't give our IV heroin users permission to inject heroin, or our crystal meth patients permission to use crystal meth, or drink alcohol for that matter. In fact, what I think one of the incredibly wonderful things about a harm reduction approach and why it is so powerful and effective is precisely that we don't take a position except that we promote health and positive change and well-being, but that we recognize that individuals that we're supporting need to make those decisions and be supported in making those decisions as autonomous human beings. And that actually one of the problems of a lot of traditional treatment approaches and criminal justice approaches is that when we start dictating to people what they should do as experts, we run the risk of disempowering them or promoting a rebellion. But there's no real support for people gaining a greater capacity to make healthy choices for themselves. And that's what we're interested in doing. Example of what harm reduction looks like in action, I run a harm reduction group. I have one patient who came in using crystal meth and cocaine and drinking. He's now got 97 days in 12-step recovery. He started going to meetings. He loves them. I have another guy who's had a binge pattern of alcohol for many, many years. He's now doing, he's 2.5 months abstinent with antabuse, his choice. He's finding it to be a useful tool. I have another woman who is now 2 weeks not drinking. She's had a long history. And then we have some folks that are very stably moderating their drinking, occasionally maybe using other substances. So the harm reduction approach is really about supporting diversity, honoring and respecting that each person is on their own path. And what we need to do as helpers and family and friends and people that care is support people in making the best choices, self-affirming choices they can make for themselves. And when we don't foist our agendas on people, that seems to be most helpful. Now, I'm not talking about when people start to really fall apart and lose it. Just as you would with any other severe mental health issue or physical issue, you move in to help save people's lives. And, but all of these issues are on a spectrum. I had another thought, which I lost. So with that, let me just say a couple of words about what we're thinking about in terms of services. Firstly, we're going to be starting monthly drop-in groups. And at this point, we've identified 5 topics that essentially one of our experts, initially Katherine MacLean, will give a lecture on harm reduction with psychedelics. That'll be our first topic, and then open up a discussion. And the discussion will really go where the group needs to go. Those topics then, going forward, will be generated by the group. Whatever the people who are participating really want to have on the agenda will make that possible. So this is a really what we call low threshold way for people to connect, to have contact with professionals and with peers and knowledgeable people in a supportive environment. And then we'll make people aware that we have other services if they really need something more professional and more intensive. We begin all of the things we do at the center with a very personalized assessment evaluation of what people need. One of the things that Katherine and I talked about early on is our shared experiences of meeting with people that were considering psychedelic use and helping them discover that the use of a psychedelic wasn't really the best solution to what they were seeking. So evaluations of motivation are really key. Why are people thinking about using, or why are they continuing to use? In fact, while it is extremely rare, which is really interesting, there are some people who develop addictive relationships to substances. I think Julie kind of alluded to that, or others did. Stefanie did. When people are using to self-medicate, or they're really using to escape or get away from something, I think that can render people vulnerable to really becoming more compulsive and addictive with a substance. So we'll be screening for that. There are also major contraindications, which some of the people here know more about than me, but about things that can really render people vulnerable to having serious trouble with a psychedelic. So the evaluation process is really a process designed to support people in clarifying their motivation, what their relationship to psychedelics is about, and thinking through what positive change goals people would like to be getting some support for. And then based on that, we can blend individual work, group work, family work, couples work. I might also say that obviously when somebody is in a crisis state with a substance, generally the people that are closest to them are also in crisis. And so we frequently work with families, in conjunction with a primary substance user who comes in. And it's really important to get the families and the loved ones on board with the model that we're working with, because if the system isn't supportive of the work that we're doing primarily, things get very chaotic and undermined. I guess that's all I really want to say at this point. I wonder if anyone here wants to add anything about... Oh, I should also say, we have in mind future services that we'd like to develop, such as a psychedelic hotline that we can make available to people globally. If people are in a psychedelic crisis and want to call in, suicide hotlines are kind of a model for that. We're really open, as I said before, to collaborating with people in creating novel services that we haven't thought of yet. So, do you guys want to share anything about...
I think we can move into the Q&A.
Yeah, so maybe we can move into the Q&A, and maybe I can invite Jen Talley. Are you going to help us with the Q&A? Dr. Jen Talley is the assistant director at the Center for Optimal Living. She's a clinical psychologist. She also is the assistant director of the mental health and substance use counseling program here. She approached me a little over 4 years ago to come and do a training here on integrative harm reduction therapy. We met for an hour and a half, and I was so impressed by this woman, I thought I need to have her working with us. So I invited her, and she said she would love to. So she's been a major mover and creator and partner in building the center, which has been really growing wonderfully over these last years. And just one last comment I want to make. I feel like we have one of the things about the center that I feel proudest about is that we very intentionally decided that we were going to do a center that has harm reduction broadcast loud and clear, even though many people still believe that harm reduction is a controversial term. What we wanted to say is that we're not apologetic about being harm reductionists. We think that it really is the most effective framework for helping people make positive change in their lives. And what we've been able to demonstrate is that we have a growing group of clients and patients. We have growing support from other health professionals and families who see that we're doing good work. And we've really put harm reduction on the map in New York City, harm reduction therapy on the map, and demonstrated that it works. So with that, let me turn it over to Jen.
Thank you. Hi, everyone. So I'm going to read some of these questions, and then we're going to turn it over to the panel to answer them. So here is the first question. What are your thoughts on psychotherapists having previous psychedelic experience, knowledge, in order to better guide sessions? Should it be a requirement? And how do we defeat the stigma among researchers to have these conversations?
I don't like the idea of a requirement. I mean, obviously, I don't like any requirements, so I kind of bristle at that. It's nice if you kind of understand where the person's coming from and what their experience is, but I think what's most important is a therapeutic alliance, an empathic connection, feeling not judged. I'm very non-judgy in my office. I know it makes a huge difference. My patients can tell me anything because I've heard it all, I've seen it all, and I'm not going to be like, oh, really? So I think that what's most important is that you're not stigmatized, you're not shamed. I don't think it's absolutely crucial that your therapist be experienced.
Something that I would add is that I have definitely experienced when clinicians have their own personal experiences, and that can kind of get in the way of the process that's happening for an individual, whether it's before the session, during the session, or in integration afterward. Psychedelics can be so powerful that for some clinicians who had a really mind-blowing particular experience when they were young, who are now still practicing decades later, they may kind of want that experience for everybody. And who's to blame them if it was a great experience and it really profoundly affected their life in a positive way? But I have definitely seen that, I think, get in the way of an individual's process, which seems to be kind of the opposite of this individualized, no agenda, helping people discover the goals that make the most sense for them. So it's kind of both.
Sorry. One more quick thing. There was a really interesting article that came out about empathy that's showing that sometimes people are the most hardened to what they've actually gone through. So you could be kind of more of an asshole to somebody who's going through something tough that you went through. Really interesting research on, everyone's all open and accepting unless they're struggling with the thing that you struggled with. So I agree that it can really get in the way.
Well, and I also just want to add that it's an interesting, as a researcher, it's an interesting empirical question, right? And there was actually I cannot remember his name, but he's up at Columbia, and he was also, I think, like an assistant to the drug czar or something like that. There's an interview with him where this was back in the period of legality when you could do psychedelic research in the United States, and he wanted to, yes, thank you. Yes, Herb Kleber, thank you very much. So he wanted to do a study. He wanted to have therapists who had a psychedelic experience and a group who had not, and see how their outcomes were. And unfortunately, he never did that study. It was, I think he was coming up with it at right about the time that sort of the door was closing for research. But it's an assumption that we have, right? That people have, and it's an empirical one. I mean, it could be maybe one day evaluated. But I want to add that my personal feeling about it is sort of in agreement with Katherine and Julie, that it should not be a requirement. Yeah.
Ready for the next question? Okay. Can you speak more to the results of the studies with MDMA and psilocybin as antidepressants, case results, and then effects of microdosing, etc.? It's a big question.
Wow, yeah.
Mm-hmm.
So I think the most important thing that to preface this is that, I mean, if we're going to be speaking about psilocybin in particular, that I don't represent Hefter, I don't represent that research team, I'm not connected to them. However, they did present here, actually, not at the New School. Well, it was part of Horizons, right? And it was at the Cooper Union. And they started to show some of their preliminary results. And from their preliminary results, saying this with caution, there was an indication that there was a response for depression in individuals who were in the end-of-life studies. And it's important to qualify that because the question is, did the psilocybin address the depression somehow, say, maybe biologically, or did it address, in some ways, again, both biologically and psychosocially, the end of life, sort of the psychological content and sort of their relation to their illness and their life, that then allowed the depression to subside, or subside. We don't have the longitudinal data for that, but at least decrease when it was measured. So it's sort of, we don't quite know yet. But what I do remember from those studies is that the effect sizes were actually quite strong, very strong. Yeah?
I'm going to make a related comment.
Okay.
I just got through standing up there and saying that we don't support or promote illicit or underground psychedelic use. But I should have also said that I think that millennia of indigenous, spiritual use of psychedelics, and then more recently over the last 20 years, and the years in the 50s and 60s when psychedelic research was legal, have gotten us to the point, I think, where we have enough data that is suggestive of the therapeutic potential of these substances, that I think that responsible professionals and citizens have a responsibility to take a serious look at supporting further research. So I think that that's where we are at this point, that we cannot responsibly support illicit use, but I think we should responsibly support the research getting to the point where we can really have some definitive answers to whether we can use them, how we can use them for this tremendous potential that seems to be suggested by current research.
And just sort of piggybacking on that, which is that I am a huge advocate of science. And when somebody asks the question, does this work for that or this works for this, it's still unknown. I mean, even in the studies, even in the study that I just mentioned, the sample size is quite small. I mean, we really need to do more research. The research is happening. And, although I can tell you, if you ask me, well, what generally are the results of the studies, I can tell you. But I think we also have to be really mindful of what we're communicating, and also that we need to be patient and we need to see what the studies say and then follow the sort of I'm an advocate for the above ground approach so that we can do this in a way that is safe for everybody who's involved.
All right, next question. So we've got 2 questions about the services themselves. I thought I'd ask those. So here's the first one. Do you envision a peer education program as part of your organization? This is something that's been very successful in other harm reduction programs. Could this involve outreach, maybe even outreach in medical settings like the ER, peers trained to help others integrate?
And the next one?
Next one is, what are the economics of operating and participating in a program like this? A research project funded by academia, a public service, covered by insurance, paid for by participants like psychotherapy.
So I'll address the second question first. It's on our minds a lot that getting individualized help can be cost prohibitive for some people. And so, however, that kind of individual help can also be priceless. And so what we've tried to do is we've tried to have the kind of staged approach of having the very kind of low cost, easy access drop-in groups that are open to the public. We are being open about our fees for that. So projected, we're hoping to do $10 for student hardship, $20 standard. And then a $50 patron level. And what we're hoping to do with the patron level, and of course, at any point anyone could contribute more than that, is to use that to offset costs for people who could otherwise not afford the individual therapy. So the groups are kind of our attempt at making things accessible and possible for people. And then from there, we're hoping that even the people who couldn't pursue individual therapy, they will have had some questions answered, maybe some fears alleviated. Maybe they'll get to talk to one of us at the group, or they'll connect with some peers. And back to the first question, I think one of the best things that could come out of the groups is that people will find other people who know what they've gone through. And I'm just as happy that people use our services or they use the peer services the peer people that they meet in the groups. So that's kind of one way of answering the economics. Yeah, one thing that I would just quickly add is that I'm a big fan of philanthropy. And some people wonder kind of what can I do if I've benefited from psychedelics or some other thing in my life, and I see this this work happening. How can I help? And this is a great way to help. If you think that it's within your means, we're going to set up a way for people to donate and a way to track that those monies go toward making therapy available for people who couldn't afford it. So that's a very important kind of premise under which we're doing this work.
But to be more explicit about the fee question, when you run a private center, psychotherapy center, or any kind of private center, in New York City, it's extremely costly. So our fees are, standard private practice fees. We do accept out-of-network benefits, and we will work with people. We will build a company, we'll take the benefits, and then, ask people for a copay. So that's one way that we can ease things. We also do some sliding scale. Obviously, it's limited, but we have some flexibility such that all of our clinicians will see people for flexible fees. I would say, though, that our philosophy is that at the center, we kind of see our center as a kind of showcase. So we're trying to create state-of-the-art harm reduction, comprehensive harm reduction psychotherapy, and create a model that can be replicated elsewhere. So we have been replicating the model in a number of different places, including Housing Works has a WASAS-funded program or license program in East New York, Brooklyn, where we've been training and supervising them to do the same kind of treatment for people who are formerly homeless, people with HIV, very poor people, and they can accept Medicaid and very low sliding fees for their services. We've also we're working with another organization in southern rural Appalachian, Ohio, who are providing largely home-based services and harm reduction psychotherapy out of Athens, Ohio, and 10 surrounding rural counties. So that's kind of a way for us to take the work and get it out into other settings where people who don't have private practice means can access them. And by the way, Housing Works is trying to set up another clinic in the East Village, so that the same kind of services will be available in Manhattan as well. There are people in the Lower East Side Harm Reduction Center who are trained harm reduction psychotherapists. Many of us have collaborated, trained and supervised them. So there are some other settings, very limited, but some other settings where people can access this.
As to the first question, I don't know about the services, but I hope that there is eventually some peer-based sort of drop-in group or something, because that is effective in a party setting. We emphasize it, that peers should be talking to peers. So it's a good way, especially for an entry point, for young people to be able to, be educated and also have this continuing care.
Yeah, actually, I should have mentioned that we do have the intention to start a peer education program. So that's part of our vision.
I don't know if this was already mentioned, but we have flyers and more information over there if you want to grab some on your way out. So here's the next question. Why isn't ibogaine on the agenda here? I will.
Is that Dana Beal?
I'm going to. Having some trouble with your handwriting. Addicts who use it to kick heroin are not intending to have a psychedelic, but to quit heroin, methamphetamines, alcohol, etc.
In other words, it doesn't fit your paradigm, but
Okay, hold it, Dana. You weren't here when I gave my preliminary talk, and I did mention ibogaine. And in fact, I'm going to be presenting at the Global Ibogaine Therapy Network. Yeah.
what I'm wondering, could you possibly enlarge your paradigm here to include people who are taking a psychedelic just because they want to quit heroin, and they encounter a psychedelic experience they really weren't counting on?
Why wouldn't it be?
Why wouldn't we? We're
Why wouldn't it
we
be?
see that there are many, many different communities of people and populations of people that are having lots of different relationships to psychedelics, and we'd like to be a place where they're all welcome and can. Oh, I should also mention that Dimitri Mougianis, who had been an underground ibogaine practitioner, and is trained in a number of different shamanic traditions, including the Bwiti, where Iboga comes from in Africa, is on our board. So we invited him on the board because we really want to honor Iboga and the traditional healing traditions as well.
I just have to say something.
Well,
This guy is not scientific. Ibogaine expresses a growth factor. It works for Parkinson's in very low doses. It cannot be understood as the other, it's just not exactly like anything. And bringing the ayahuasca guy in to talk about ibogaine is just not appropriate.
I'm a little bit confused, but it could be because of my postpartum brain. What I will say is I would love to have one of the drop-in groups be about iboga and ibogaine. I know very little about it. I'm fascinated. We've tried to select an advisory board that cuts across a lot of the territorial, kind of carving out areas of expertise within the psychedelic research community and beyond into the shamanic communities. We're also trying to respect the fact that people who come to get our services are looking to us to be as professional as possible and to have credentials that you would look for in any kind of medical setting. So it's a balance, and we're trying to do something a little bit new. And we're going to learn as we go. And so this kind of feedback is really helpful. We could have easily had a 5-hour program tonight and featured experts on ayahuasca, ibogaine, LSD, all of DMT, all of it. They're out there. But we had to select what we thought was a program that would best address the research and the underground use. But thank you for your question.
All right, so this question is directly for Ingmar. How did the experiences and methodology of the Czech psychiatrists compare to that of the psychiatrists in Saskatoon, Canada? And how did the politics of the Soviet Union affect the Eastern Bloc doctors' work? I know it's a very complex question, and I'm just seeking a short general comment. Thank you.
Wow. I mean, I'm thinking about what piece would be most interesting to respond to. So there were generally 3 models that we looked at that sort of came up when we did these interviews. One was sort of this psychotomimetic model. So this idea that somehow, they were particularly looking at LSD the most, that somehow it mimicked psychosis. Then there was a sort of the psycholytic model, which was a blend of sort of psychoanalysis and low-dose LSD, and then the sort of full psychedelic model. So more gearing towards inducing a mystical-like experience. Those were the 3 models that were used. The psychotomimetic model was actually probably most dominant of that came through, which is interesting. It's something that we don't really think about very much today. But many of the people that we interviewed said that one thing that they took out of their training was that they could actually relate better to people who had schizophrenia, understand what it might be like to have a delusion, or to be sort of more intensely paranoid. The interplay between that work and the Soviet Union is very fascinating, and it's a very in-depth story. But maybe one thing that I can make a plug for, there's a lesser-known book written by this author named Milan Hausner, and it's available in English. And many people have heard about Stan Grof. Not many people have heard about this author. And he really met an unfortunate end. What he did contribute was he had done something like 3,000 psychedelic sessions, and he had a whole clinic that was devoted to all sorts of therapies using primarily LSD to treat patients. And really, his book is about his model, and it's fascinating. And the way that he met his unfortunate end was that the Soviet Union. Maybe to add, the way that the Soviet or the Eastern Bloc kind of used LSD was to demonize, to use it as propaganda, unsurprisingly, right? So they saw that people were using these psychedelics in the United States, and they were able to say, look, those imperialistic, hedonistic people are using these drugs, and they created this narrative. In the communist Czechoslovakia, there was no very almost minimal use of these drugs outside of the clinical setting. It's sort of unique in that way. But once the communist regime sort of whipped up this demon, they then said, well, then we can't allow our scientists to be studying it here. I mean, so they clamped down on it. And one way that Milan Hausner really ended, unfortunately, was that he killed himself. He felt that his life's work. I mean, he devoted decades of his life to this, and he spoke about the changes that he saw. And there's different theories about what was going through his mind when he ended his life. But that what many people said was that he was just completely heartbroken that this research was clamped down, and that is a consequence of the totalitarian regime that he lived in. So there are many more stories, many of them more positive than one that I introduced, but I felt like sort of to honor him and his work, it would be important to mention that. Yeah.
All right, next question. Define mystical experience. Are there more than one type?
I'll give the quick definition that was used in the studies, because, we could kind of debate the definition of mystical experience for quite a while. In the Hopkins work, we used criteria that had been first kind of quantified by STACE, and they include unity, external unity, and internal unity, so feeling interconnected with everything, or on the kind of flip side, the void, or kind of there's only one thing, to the exclusion of all of the different forms. A feeling of knowing that the experience is real, and more real, in fact, than your ordinary waking life. A sense of sacredness, and sacredness does not necessarily mean encounters with God or something supernatural. It could be just something that you consider to be more meaningful and that can be profaned in your life. The other qualities are transcending time and space, extreme positive mood, and ineffability. And somewhat not having the words to fully describe something. So the funny thing about psychedelics is pretty much everyone says it's really hard to describe what happened to them, but everyone uses a lot of words to try to describe what happened to them. So those are the definitions we were using, and then the person had to basically max out each of those categories in order to get a complete mystical experience. So you couldn't end up in a category of mystical experience if you were completely missing one of those categories. So that 70% is basically people who rated high on all of those categories in a single session.
Can you please talk about your work with openness just for a sec? I think it's important.
Sure. So In the first two studies that were conducted at Hopkins, they were healthy individuals, very high functioning, spiritually inclined, who were naive to psychedelics, and for the most part, barely used any substances. The standard finding was that these people had, for the most part, a very positive experience. For 70% of people, it was mystical in nature. And in the long run, people were saying, this really improved my life. It was among the top most personally meaningful experiences of my life. It was one of the most spiritually significant experiences of my life. And they were still saying this a year later. And all of their friends and family members were kind of corroborating their claims. These weren't just people kind of on their own trip. Their friends and family were saying, yeah, I agree. This person has become actually a lot better. When I came along to Hopkins, I wanted to look at whether there were any kind of other changes in variables that are expected not to change. And so one domain is personality. And for all of the kind of theories and controversy within any field of psychology, personality psychology is actually pretty consistent in that everyone accepts that these 5 domains exist. They're fairly cross-cultural, and they're not supposed to move around that much. So you kind of develop your personality into your early adulthood, and then it's pretty solid. It's solidified about at the age of 30. It seems kind of almost expected that if you had a major life event that your personality could shift a little bit, but no one had really ever shown that, except in people who were recovering from a serious addiction or depression. So treatment recovery looked like a personality change in some contexts. But no one had ever shown that personality could change from a single life event. And it's kind of hard to be there when that happens. So what I did is I looked at whether personality changed from before to after the high-dose psilocybin experience. And for the most part, the findings were boring. It was kind of like no change on this dimension, no change on that. Basically, people looked the same, except one domain, openness to experience, increased. The increase was small across all the people, so it was about 50 people. But if you just look at the people who had a mystical experience, the amount of change was at least as much as anyone else had published in any other population. So people who were recovering from various addictions, people who were recovering from depression, the increase in openness was as big as anyone had ever published before. And this was in very healthy, high-functioning people who, by all accounts, should not have been changing that much. And they were high in openness to begin with. Kind of more surprisingly was 2 months after the session. A year later, their openness was exactly as high as it had been 2 months after they had taken the drug. Now, the people who had had the exact same dose but didn't have a mystical experience, their personality and openness stayed the same. So why is this a big deal? Well, openness is related. Openness typically declines as you age. Mm-hmm. So you become more rigid, more conventional, more fearful to try new things as you grow older. So that's kind of interesting. Psilocybin makes people almost young again. And there are good things about that and bad things about that. It makes people more interested in music, art, fantasy. Openness is also related to empathy and experiencing feelings of yourself and others. And it also predicts how conservative or liberal you are on a political spectrum. So you can see that this finding is exciting. On the one hand, it's kind of helping people have a broader perspective on life, but it's also a little controversial in that it's kind of the worst thing that people anticipated from the 60s, is that all these liberal people are taking psychedelics and they're becoming even more liberal, and it's just this like horrible feed-forward loop. Now, the upside is that this finding is there in the literature, and no one can really dispute it, even though I've encountered editors in psychology journals who would not even review the paper because they said the findings were unbelievable. Okay, so it's published in a drug journal, but I would love to see that work move into the psychology field, studying creativity and other things that openness is connected to. And of course, this was just 50 people. So I would love to see if in some of the therapy sessions, people's personalities also shifting, which I believe the MAPS MDMA clinical trials has a paper under review still that is showing personality change from before to after MDMA-assisted psychotherapy. And it's kind of the similar effect. If you have a reduction in PTSD symptoms or a recovery from PTSD, you show changes in personality. And if you don't show improvement or recovery, your personality stays the same. So that paper's been under review for a while, and I'm sure they're running into the same problems that I ran into, having people take it seriously, because it is actually unbelievable that you could get such a change from a single drug experience.
On the single drug experience topic, I couldn't figure out what to call it. I just have to share something that's really quite amazing. A little factoid. Richard Jensen and Donna Dreyer did a 35-year follow-up interview with one of the Spring Grove study subjects from 1965 who was in the study of LSD in the treatment of alcoholism. And they had very, very powerful, robust results. This particular subject, for some reason, back in the 60s, became public. He was interviewed for Life magazine. So, so they thought they would find him if they could and interview him 35 years later. They actually wrote up a paper that they completed, I think, in the year 2000. And what they found is, A, he stopped drinking after one single LSD session. He credited an insight that he gained on that LSD session to helping him to stop. It just it lifted the desire to drink. And he'd never had a drink since then because of that. He had been this falling down drunk longshoreman. So, I mean, he really had a kind of horrendous drinking history. So there are many reports of this kind of thing. Although I think it's just important also to add that when we think about problematic relationships to substances, I think we're moving away from in the addictive behaviors field from this kind of one truth, one disease, one perspective or paradigm approach to really seeing problematic relationships to substances as varying on multiple dimensions, so that each person's problematic relationship is highly unique to that person, and therefore the goals and approach have to be highly unique as well. So, of course, there are many people who will take a substance and it will in no way change their relationship to other drugs. They need, other kinds of interventions.
All right. So I've got two questions that are kind of along the same thread, so I'm going to ask them both. What difference does it make which drug caused an experience, psychotherapeutically speaking? How are research chemicals changing your work? And then, are psilocybin mushrooms all the same? Question mark. Surely not! Exclamation point.
I'm not quite sure that I understand the first question. Can you say it again?
Sure. What difference does it make which drug caused an experience, psychotherapeutically speaking? I'm not sure if the person who asked that is here and wants to clarify.
Do all psychedelics do the same thing?
Yes. That's the question.
I think it might be like it doesn't matter, right? Like if somebody had an experience that is like they took MDMA versus they took psilocybin, like does it matter, like the reason that they come in, or does it change anything when you come in, like when the therapist would talk to you? Like they're like, oh, well, you had this experience as a result of MDMA, so this is my strategy. I think that's the question.
We have somebody with a hand.
He's here.
Ingmar. So sorry. So to clarify the question about the nature of the substance, the question is basically psychotherapeutically you're working with whatever experience comes up. So I was interested in if people take some research chemical and you don't know the nature of it, or you don't know what was sold as MDMA, how does it change the psychotherapeutic process? Does it matter? I mean, people have an experience, period.
No, I think that's a good point. I mean, we could also even potentially talk about a placebo effect. Are they expecting to have a certain kind of experience, and then the becomes true, and then that's how they talk about it. I think, what is also coming into my mind are sort of, patient variables, right? So that's also going to have an effect in terms of how of the psychotherapy process and how you're going to work with somebody. So, in some ways, no, but I mean, now I'm thinking of a scenario in which a person had an experience, pursued a certain drug expecting some sort of effect, and then didn't have it because they didn't get what they, maybe, we can't verify it, but maybe it wasn't what they wanted. And then working with that kind of feelings of disappointment in it. So, I mean, yeah, I don't know if that answers your question.
I will say in the festival, the nightlife context, I mean that when somebody comes into Zendo, like you do ask them, like, what did you take, and you want to know, but they may or may not know. Like they might say LSD, we don't know. Like, we might anecdotally be like, well, you're acting not like somebody who is on LSD, but we have no way of knowing. So that's like kind of in a real life setting. You have to kind of go with, again, like what's presenting and just be like present in the moment with that person and just, be reacting to like what's happening at that moment. I think, now with my policy advocacy hat on, like this, people's experiences like saying, oh, I went to a festival, I had LSD, I had this terrible time. This is going to be an impetus to advocating for, LSD or like research or anything positive around it, because people might not have an actual honest idea of what they've taken. So I guess it changes based on the context.
Okay. So someone's asking. Sorry.
There was another question embedded in there. Yes, there are many different types of psilocybin mushrooms. Some of them are way more potent than others. And what we were working with at Hopkins was synthetic psilocybin. It wasn't extracted from any mushroom. It was completely made up in a laboratory. And so we know exactly what people are getting. It's one chemical. In mushrooms, there are many different types of chemicals. It could be that when you take a particular mushroom, it's a certain amount psilocybin, a certain amount psilocybin, a certain amount baeocystin. There are a bunch of other chemicals in there. So the science on mushrooms is almost negligible. I mean, it doesn't exist yet. And I think that would be an exciting avenue for future research, is to look at the effects of the mushrooms themselves. The tricky thing is dosage and controlling the effects across people. And also just that people get really physically ill. People don't really get ill on synthetic psilocybin.
Can I add something to the conversation that's probably obvious or known by most people, but we were also talking about this at lunch. A few of us had lunch. There's the concept of drug set and setting, which Timothy Leary came up with. Norman Zinberg from Harvard also talked about in terms of understanding the relationship to the substance, as opposed to Leary's idea of understanding the drug effect. That the mindset and the setting are key to the experience that people are going to have. So imagine, or maybe Katherine can tell us, what that very special setting was in, or is, in Johns Hopkins. We were talking about the powerful positive transference that the subjects have to Johns Hopkins, right? And like the scientists at Johns Hopkins. I mean, they must know what they're doing, right? Mm-hmm. So you're really safe. As opposed to hanging out with your friends, in a club, and you don't really know them that well, and you start getting anxious. If you can replicate, and I think that's what a lot of ritualistic use of substances is about. It's about creating a certain setting that has tradition, that you can count on, you can believe in.
If I can quickly add, there's something that connects between the research that I did with the individuals who were using the mental health professionals who were using these substances in the former Czechoslovakia, and some of the things that I've heard from some of the patients in the MDMA and in the psilocybin studies, and which Andrew has touched upon, which is that one of the questions that we posed to the mental health professionals was, what was important for you to be safe when you were undergoing this experience? And they all said that they knew that there was a colleague, a doctor that was there with them. That really allowed them to feel safe and have their experience. And I've heard the same things from people who've gone through the psilocybin research. And so when we are talking about our program and we're thinking about these things, I think that's something really important to consider.
So I'm gonna. Oh, I'm sorry, Catherine.
I really want to emphasize that any of the positive outcomes that you read about, the chances are very, very, very small that you will be able to replicate that for yourself in the real, ordinary world outside of the medical institutions. We had very serious, committed, enthusiastic psychedelic users who took part in our studies. One of the reasons was to advance science, but a lot of them said, I could do this on my own, but there would be a part of my brain that is remaining vigilant for what if something happens outside, what if something happens to my friend, and they could never actually completely surrender and let go to the experience. And so that speaks, I think, to even the people who know exactly what they're doing would choose to do it in this kind of safe and controlled setting. There are, of course, drawbacks to that setting, but the safety is paramount. And with psychedelics, when people feel really safe, that's when I think the most positive transformation can happen. So just remember that when you kind of read how awesome things seem coming out of the research studies, it's really not reflective of how the experience is for a lot of people out there in the world.
All right, so I'm going to ask one last question, and then for those of you whose questions weren't answered or who just want more information, we really encourage you to email us, to join our listserv, to go on our website, and our new website is, you want to say it?
Yes, it's psychedelicprogram.com, and currently it's redirecting you to the Eventbrite page, but it will redirect you after tonight to the actual page.
And the email address is info@psychedelicprogram.com.
But our general center website is centerforoptimalliving.com. And if you want to find out more about this program and the Board of Advisors, on the top we have a tab called Programs. And right now the only program that it will take you to is the Psychedelic program. And we can credit Ingmar for the beautiful work on those pages. Thank you, Ingmar.
Yeah. All right, so here's... So last question, and then we'll wrap it up. So what advice can you give a student who is pursuing a career in psychedelic psychotherapy? Where to go and who to speak to?
I can tell you right now, you can get practical experience if you volunteer at Zendo. It's mostly a West Coast thing, but we're trying to figure out how we can get something like that going on the East Coast.
On the website maps.org, there's definitely a tab about people who are looking for graduate studies or looking to network to do this kind of work. So there is at least a listserv, if not more, on maps.org.
I mean, I have had many people come up to me and ask the same question, and I love to speak to them and really find out what their curiosity is, because I think that's the most important thing. That if you're going to be engaged in this, what is it about that kind of work that you are interested in, and then really nourish that. But one thing that I would say is what worked for me was working really hard and showing the program, the clinical program that I was in, that I was very serious about clinical work. And then I think that allowed people to then sort of see that this is not some odd, weird thing that I'm interested in, but something that's serious and has potential. So work hard and identify what your curiosity is, and then nourish it. Yeah.
So in closing, I want to thank the team from the Psychedelic Education and Continuing Care Project. I want to thank our amazing Board of Advisors, and I want to thank all of you for being here, and I hope we can keep a conversation going. Have a good day.